Hi, everyone. Thank you so much for joining us for this session today on support in the time of COVID, and thanks for sticking with us at this point in the day. I'm Andrea Goodman with the Colorectal Cancer Alliance, and we have a really exciting session to help us understand all of the ways in which the pandemic has affected our path through colorectal cancer. So without further ado, let me introduce our panel today, starting with close friend of the Alliance, Dr. Christopher Liu, Associate Professor of Medicine and Associate Director for Clinical Research at the University of Colorado Cancer Center, who will share some thoughts on fear about COVID and safety in the hospital setting today. Carol Weska, Lead Clinical Medical Oncology Triage Nurse at the Sidney Kimmel Comprehensive Cancer Center, who will tell us about telehealth visits and new ways of doing healthcare during COVID. Katrina Pertel, Clinical Research Nurse Manager at Johns Hopkins University Hospital, who will speak about changes and challenges in clinical trials and research during the last 8 months. And finally, Trudy Loper, Senior Director of Screening here at the Colorectal Cancer Alliance, who will share an incredible new opportunity to accelerate colorectal cancer screening, even in this time of crisis. So welcome to all of our panelists. Thank you for being here with us today. Dr. Liu, let me start with you. We know that so many people listening today have been struggling with new decisions. Do I delay a treatment or colonoscopy due to the risk of COVID at the clinic? Do I change my cancer treatment regimen due to reduce the risk? And on top of managing treatment or surveillance, it's just a lot to weigh. So what do you suggest to people around managing their risks? And what are you been seeing right now in COVID-19?
Andrea, thank you so much for that question. And thank you everybody for joining and taking time out of your day to have a conversation about what is obviously such a very, very important topic in time. And so I'm going to take several minutes to discuss managing risk and fear of COVID. I'm a GI medical oncologist at the University of Colorado Cancer Center. And I kind of figured that it would be good to start out with just where we are in terms of COVID-19 and the United States. And so over the next couple of minutes, I'll just give you a quick update on how rapidly things have changed over the last several weeks, but then also focus on COVID-19 and your health because the impacts on the individual level are certainly significant as well, especially if you're dealing with a diagnosis of cancer and or colorectal cancer. So a quick update on COVID-19 and how we're doing in the United States. I won't take a ton of time here going over a lot of data because I'm sure you're inundated with all kinds of news stories about how COVID-19 has changed across the country over the last several weeks to months. But I'm going to start with a curve or a graph that you guys may have seen several times before. And what you're looking at are the effects of social distancing on the 1918 flu in the United States, and looking specifically at two separate cities, Philadelphia and St. Louis, and how impressive the impact is of social distancing in one city, St. Louis, compared to kind of laxer restrictions or later restrictions, which is what occurred in Philadelphia. And what you're looking at is unfortunately death curves from the population in Philadelphia and St. Louis. And there are two real take-home messages from this graph. The first one is that the less social distancing that you have, obviously the greater impact on the population. And you saw that in Philadelphia in 1918. And you saw this incredible spike in cases that happened relatively quickly. But of course, the duration of the pandemic in that particular city was somewhat short when you look at it, because obviously there's a tremendous amount of death and overwhelming of the current healthcare resources at the time. And then compare that to St. Louis, where social distancing was enacted very, very quickly. And the other take-home point, besides the flattening of the curve here, is really that it really extended how long the pandemic lasted. And so certainly that was reflected in the lower death rate, but it did also reflect in the sheer length of time that St. Louis was dealing with the pandemic, which I'm sure everybody on this call is feeling as well. You also see this other spike that happened in December in St. Louis, showing that there was another wave that hit the city as well. And I think that we're seeing some of those effects as well. So what you're looking at here is the United States COVID-19 death curve, and you can see a rapid rise in deaths from this disease over the course of the spring, and then a relative flattening of the curve over the summer, though we knew that there were several hotspots that occurred during the summertime this year. And of course, what you're also seeing is this continuous rise, particularly in the fall, but that the curve has remained fairly flat for the most part without these gigantic peaks, and that really is a success of social distancing and mask use. What this curve also shows you are projections of death rate if the social distancing rules are relaxed and if masks are used. And so you can see where the dotted line and red line and the dotted green line differ significantly. And of course, what everybody on this call knows is that, we had a rapid rise of cases in the spring, a little bit of a lull, but then another rapid rise in the summertime, and then another lull kind of in September. And then what we're seeing here is another rapid rise in cases of COVID-19 across the country. Now, the caveat to this graph is that, of course, the more you increase testing, the more cases that you're going to find. And so certainly this also reflects greater incidence of testing, but we're also concerned about the increasing rate or percentage of positive tests that we're seeing in the tests. And that's why we're having the rise that we're seeing today. One of the biggest things that we worry about is obviously overwhelming the healthcare system and the hospital system with patients needing significant care for really severe cases of COVID-19. What you're seeing here in the dotted purple line is the hospital resource use for all beds. And then what you're seeing in the dotted kind of green and blue lines are how many invasive ventilators are needed and how many ICU beds are needed. And of course, over the course of the next several weeks to months, we expect hospital resource use to increase. And what you see on the right side of this curve and the shaded areas are kind of the level of error that there may be in these projections. And so, what we're really trying to do over the next several weeks to months is prevent the hospitals from being overwhelmed with patients needing beds and patients needing ventilators to combat this disease. And in case you ever wondered if Big Brother was watching your cell phone use, what you're looking at here is United States social distancing as measured by cell phone mobility data. And you can see over the course of this curve, a tremendous decrease in social mobility as measured by cell phones in the spring. And then as everybody knows, over the course of the next several months, we saw an increase in mobility of our population. And I think that this does contribute to what we're seeing right now in terms of the increase in cases. But I do want to provide some good news. Obviously, we're preparing for the future. We're increasing testing capacity. We're increasing our supply chain for personal protective equipment. And this is critical to protect hospital workers, but also our patients that are in the hospital. And then, we're enrolling patients on the vaccine trials. And this is the fastest vaccine development that we've ever seen. And so we're hopeful in 2021 to have not only one vaccine, but potentially multiple vaccines that are approved for use. So all this kind of gives you a background of where we are with COVID-19 in the United States, but more importantly, what about your health during the COVID-19 pandemic? And part of this is just a reassurance to everybody that's on this call to tell you that really intra-hospital transmission rates of COVID-19 are very, very low, which means that you should feel comfortable going into a hospital and receiving the care that you need without having to worry about contracting COVID-19 within the hospital environment. For the time being, elective procedures are ongoing, but I'm going to put a caveat here, and I almost need to timestamp the fact that this is late October 2020, because even though elective procedures are ongoing in many states, that may stop in the near future, depending on what the infection rates look like in the future. But as it stands right now, screening procedures are ongoing, which includes critical things like colonoscopy and mammography. We're worried as a healthcare organization that there could be a concern for stage migration, catching a cancer at later stages of disease where it's harder to cure. So we really want to get the word out to get your screening procedures, to not ignore your health during this critical time. We also had an urgent and rapid shift to telehealth medicine. This would have taken many years, and a lot of hospitals accomplished this within a couple of weeks of offering video visits, telehealth visits to patients. And just keep in mind that this is a great way to catch up with your medical team if you don't need to come in for a particular test or treatment. But really, one of the big take-home messages is also continue your treatment plans. We can sometimes limit treatment plans to limit exposure, but it is critical to continue your treatment. Another couple of notes that cancer research and clinical trials are ongoing. And so we know that we're continuing to accrue to these important clinical trials that are really part of just the normal care that all patients diagnosed with cancer should have access to. We know that testing capacity has increased and is becoming more efficient. The death rate has decreased compared to what we saw in the spring from COVID-19. And a lot of this is simply better management, better therapeutic options to combat the disease. And as we mentioned before, vaccine trials are ongoing. So really, some take-home points. COVID-19 should not prevent you from taking great care of yourself. Part of this is just really good communication with your care team in terms of what you need and how you're feeling, and just make sure that your needs are being met and your medical care teams are there available to you to make sure that you are taken care of. And certainly, we talk about cancer care and we talk about ICU beds and the need for invasive ventilators. Do not underestimate the impact of all of this, the pressure of the pandemic and everything going on and social distancing on your mental, your physical, and your spiritual health. So, just a real, plea to just make sure that you're doing everything in your power to take great, great care of yourself. I wanted to end this just with some support in terms of COVID-19 information, but and pretty much every hospital has these support websites up, but I'm just giving you one from the University of Colorado School of Medicine in terms of resources to use during this very, very difficult time. And with that, I really appreciate you guys taking the time to join this call, and very, very honored to be part of this discussion and to be here with you today.
Thanks so much, Dr. Liu. I think that is probably really comforting and reassuring to people as they're planning for treatment decisions during this time. So Carol, I'm going to turn to you as a triage nurse. You've had to totally pivot the way you practice effectively during COVID. Tell us about what's new for you in terms of telemedicine and other changes of visits during this time.
Okay. It's a pleasure to participate in the conference. I wanted to put a face to triage. I am the number on your refrigerator magnet. I am the number in your discharge paperwork, your clinic chemo education class. So I am the nurse that you speak to on the phone whenever you call the triage number. We speak to about 600 or 700 calls, email messages weekly. That has seen approximately a 20% increase since the pandemic. We are available Monday through Friday, 8 to 5. However, we do have a doctor that covers the evenings, weekends, and holidays, and can answer any questions or concerns that you may have. We partner with a small oncology urgent care center that is available for our patients in active treatment, and we have managed to increase that space from 7 beds to 14. We've included negative pressure rooms so that we can see and treat our patients who screen positive for COVID or who are actually COVID and are still requiring treatment. In addition, our radiation oncology also has negative pressure rooms so that we can continue to treat our patients. We in triage can work remotely. We also have offices on campus. However, we do not interact very often with the physicians or nurse practitioners. There are about 3 buildings, 2 cancer treatment buildings, a number of offices. Sometimes the doctor is the inpatient attending. So we will communicate mostly through email or secure chat on the electronic medical record or through chorusing. But we're not quite as face-to-face as you may see at your primary care practice. A large amount of our calls are symptom related, and I'm kind of just wanting to run through those with you because they do kind of correlate and worry our patients with regard to COVID. Nausea, vomiting, and lack of appetite are probably at the top of the list. We do a lot of education over antiemetics, dietary choices, hydration, those types of things. We do also offer nutritional support that is available via a telemedicine visit. So our nutritionist can offer you much more specific education, suggestions on supplements and meal planning. So that's a benefit that is available if you are in person and receiving treatment or over the phone. Weakness and fatigue are another common symptom. I believe that we talk about fatigue, but what our patient experiences is severe exhaustion. So we kind of have to get on the same page with what they're experiencing is okay. We can provide physical therapy, occupational therapy. This can be done in the home if they're comfortable with that. This can be done in a rehab facility. We just want people to stay active and not limit what they're doing because of their fear of COVID. They can still go walk outside. They can wear their mask and go around their neighborhood. And we want them to feel safe doing that. Our social work is very helpful, very available on the telephone, telemedicine visits, providing support and community resources. I think that when people experience pain, they're worried that their cancer has spread. They're worried that their pain may not be controllable throughout the course of their treatment and disease. We offer a lot of education about addiction, pain management, and we can refer to our pain and palliative care team that is very much available through telephone counseling and support. A lot of our patients do I believe, cost comparative with their prescriptions and get things through Costco or Walmart, which are wonderful. They're also big box stores, and there's some fear with going there in the evening when maybe it's more busy. So we do offer medication delivery. Finally, constipation and diarrhea are also a big concern and a problem that we review. We do education. We manage with over-the-counter medications and assess for dehydration. We can arrange home IV fluids, or we can arrange for you to be seen in our very small urgent care facility so that you do not have to be seen locally or through the emergency room. What I've seen in the pandemic is that patients are feeling they have to balance their anxiety and concern over exposure with actually being treated. And that's what we don't want to happen. We want to manage your symptoms safely, and we want you to have confidence that we can do that we have prepared a way to take care of all of our patients, and we have done that. I think the frightening thing is the treatment side effects of headache, muscle aches, low-grade fever. They all are on the same list for COVID. So we try to tease out where the patient has been when these symptoms started. And if necessary, we bring them into our COVID area of the urgent care clinic that we have. But the biggest thing is that we want to provide prompt, safe management of their symptoms. And that is our goal, to continue to treat people in the best manner possible. To keep everyone safe, we've limited our visitors, and there's a strict no visitor policy. So we really try to stay in touch with people. We encourage them to bring their phone, their charger. We have deployed staff from same-day surgeries and elective procedures that help us, that help transport patients and help them navigate the system alone. New patients are welcome to bring a person with them at their visit. If your visit is going to involve a discussion about changing your plan of care, we can make exceptions to that visitor policy. As I said, we did expand our urgent care rooms. We deliver medications. Groceries can now be delivered. Church can be drive-through. So we do try to manage our lives and plan what we can do during this time of COVID. As a nurse, I recommend kind of separating from the news, from social media. I encourage many of the free meditation apps that are available, listening to music, reading, puzzles, those type of activities, I think can really help manage the fear. And I think staying in contact with family and friends is very important. People are still concerned about travel. Returning to work is a big problem as people are trying to reopen society. But social support is very important. We have provided, of course, as Dr. Liu said, we have shifted into telemedicine visits, which is wonderful. But some people feel that everything can be managed remotely, and I want people to still appreciate that your safety is utmost our concern. But there are times when you need to be seen in person and have an in-person physical exam. You need to come in and have your scans. So that's the only downside I've seen, is that we have embraced this and people would like a lot more care remotely. However the future looks, we are definitely committed to providing safe, accessible care for our patients. And I hope this has given you some insight into what triage does and what services we can provide for you as a patient or as a caregiver. Thank you for attending this conference with us.
Great, thanks so much, Carol. I know that rules and guidelines vary by hospital and location, but these tips on safe management are so helpful to many people listening today. Katrina, I'm going to turn to you now because I know another big change during COVID has been in trials. And we've heard from many of our community members watching today who have shared that they're devastated when trials are paused or delayed, as we've seen over the last 8 months. It can mean a treatment option that they were expecting is no longer available. So tell us about what's happening now in clinical trials. What are you seeing?
Thanks, Andrea, for inviting me to speak about the challenges that we have faced in clinical trials during the COVID pandemic. For those who are not familiar with clinical trials, a clinical trial is a research study to find out if a new treatment provides better outcomes than the existing standard of care, which is the best available known treatment. Clinical trials are conducted to establish the effectiveness and safety of new cancer treatments. The difficulty with finding effective drugs, whether it be chemotherapy or immunologic agents, is that there is still a lot we need to learn about the makeup of cancer cells and what can eradicate these cells without harming healthy cells. Discoveries are being made about biomarkers and proteins that make up these cancer cells, which will allow us to provide targeted therapies based on that particular tumor. With targeted therapies, we believe that being on a clinical trial is the top recommendation for treatment, especially if we can match a specific type of cancer and the mutation to a particular therapy. An example of this is microsatellite instability mutation in colorectal cancer. Through clinical trials, we have found that patients who show the MSI high mutation are more responsive to pembrolizumab. With FDA approval, pembrolizumab is now considered standard of care for this population of colorectal cancer tumors. The treatments that are currently considered standard of care became standard of care after going through an extensive clinical trial process. Yet, fewer than 10% of adult patients with cancer in the United States enroll in clinical trials. Some barriers to clinical trial enrollment are logistics of extra visits and having to miss work, traveling to the cancer center, which can take a financial toll, and lack of resources. These challenges still exist and now are compounded by a global pandemic, adding an extra layer of difficulty in advancing cancer research. According to the Cancer Research Institute, over 200 oncology trials were interrupted in March and April due to COVID-19. A survey done by IQVIA found that 20% of institutions in the United States enrolled at the same rate. 20% completely halted enrollment, and 60% enrolled, but at a slower rate, which is what Hopkins did. The short-term impact of COVID-19 on cancer research, from our experience, is that studies are behind on enrollment, which means there will be delays in publishing results, which is important in writing future protocols. Additionally, there are less clinical trials being activated because the criteria to open a study safely has increased due to COVID. Establishing the effectiveness and safety of new cancer treatments requires multiple doctor visits, extra research labs to be drawn, and extra tumor biopsies to study the effects of the drugs on the human body, more so than the standard of care treatment, which has already been extensively studied. Because of increased interaction with staff and other patients, many centers put a pause on new enrollment, and a thorough risk-benefit assessment was performed for patients to continue on treatment. This was a very scary time for those who were being diagnosed with cancer and those who were looking for alternatives to standard of care. It was extremely frustrating for our doctors and nurses to have our hands tied. But ultimately, patient and staff safety were our main concerns during this early period of the initial surge, especially during this uncharted territory for the healthcare community. The uncertainty of COVID-19 required us to mitigate risks in our immunocompromised patients. We were able to continue clinical trial participation for those who were already enrolled. We performed televisits and focused on safety for the patient by decreasing research blood draws, especially when a patient had been on a study for quite some time. Patient access to the televisit technology was a factor in making this a successful process. Patients who received oral investigational drugs had the option to do the televisits, and the drugs were then mailed to them. So essentially, we were able to adapt and make it work for the patients who were already on study. Our cancer center was able to enroll new patients through an emergency appeal process, but had to justify that there was no other alternative to treatment and that the interaction between patient and study staff would be minimal in order to decrease risk for infection. We remained in emergency enrollment from March through June and enrolled 128 patients. To put this into perspective, we usually enroll 120 patients a month. So essentially, we enrolled 25% of our usual enrollment. In July, we were allowed to enroll at 25% of our monthly average without the emergency process, and increase another 25% every 3 to 4 weeks, ensuring that we were able to ramp up our research activities safely and efficiently. We put processes in place such as teleconsents and telemedicine, as well as social distancing guidelines for staff, in the hope that in case of a second surge, we would not have to fully shut down like we did in March. In September, we enrolled 75% of our average monthly enrollments. We hypothesized that the reason for this could be that the patients don't want to come in for long research days, which have been reinstated. Also, travel restrictions from one state to another are changing from day to day. The restrictive visitor policy that Carol mentioned could be a factor, especially for those who need a companion during treatment, and that can be a hardship for some. Additionally, there could be a public perception that there's an increased risk of exposure by going to a major hospital that takes care of high-risk COVID patients, and that may not go away until we have a COVID vaccine, and that we feel like this COVID is under control. So on top of the safety measures we implemented with telehealth, our clinic and research nurses call the patients the day before treatment and review symptoms with patients prior to treatment. So that could potentially review potential delays in treatment. We were able to add COVID screening to this process with little difficulty. Carol alluded to that we built a separate biomode area that has negative pressure rooms to treat COVID patients who are well enough to receive chemotherapy and other supportive care, such as blood products or IV fluids. About 4 to 5 years ago, our GI cancer program established a clinical trial referral team consisting of nurses and a coordinator. They speak with patients interested in clinical trials, and they review medical records and assess eligibility even before a patient makes an appointment to see one of our physicians. This process has decreased the number of patients who travel to our center only to find out that they're not eligible for any of our clinical trials. While we don't know the long-term effects of COVID-19 on cancer research, some of the changes that were made may allow more access to patients who have trouble with the logistics of frequent visits to the study site. Some studies have allowed safety labs to be drawn closer to the patient's home, and sponsors and investigators may use this pandemic as an impetus to review how often patients need to be seen in person, but still capture the necessary safety data virtually. In turn, the cost to participate would decrease with less on-site visits. Telemedicine and teleconsent will remain to some degree, depending on insurers and their willingness to reimburse for telehealth. These changes may help us increase participation in the future, making up for setbacks caused by COVID-19. This may allow access to more clinical trial participants, further advancing cancer research and improving outcomes for our patients and their families.
Thanks so much, Katrina. I just want to make sure also that our listeners know that the Alliance has a really great clinical trial finder tool on our website, ccalliance.org, that will take you through a questionnaire that will get you to a list of trials that might be right for you. And if you have any questions about that, our helpline navigators can help support you through the trial finder tool as well. Thank you so much again for your time. And lastly, Trudy, I'm going to turn to you because we know we've seen a big decline in screening rates, and the Alliance is really worried about this. So we've been working on big plans to overcome these challenges to screening during COVID and beyond. Can you share with our listeners today, who are such big champions for colorectal cancer screening, what you have been up to?
Thank you so much, Andrea, and thank you to all the attendees today. We are super excited to unveil to you what we've been working on in response to these declines in screening. We know that there was about a 90% drop in screening just between March and June of this year. And we know that that doesn't mean that there was not colorectal cancer to be caught and diagnosed during that time period. So we really want to address those delays. So what the Alliance has been working on is an awareness and campaign and patient navigation. I'm going to go into that. Specifically, our campaign goals here are to save lives by increasing colorectal cancer screening rates, by reaching at-risk and underserved communities, to increase awareness of screening, and also driving engagement with a patient navigation tool that helps patients find screening options that are right for them. We also wanted to reach providers with messages and resources to really reinforce the urgency of the resumption of all forms of colorectal cancer screenings. And we know that, as Dr. Liu mentioned before, we have seen these preventive screenings increase since this summer, but it hasn't been uniform across the US. We also wanted to tie into a long-term strategy that the Alliance has been working on, moving towards patient navigation for colorectal cancer screening today and really beyond COVID-19. So this gave us a great incubator to really test, learn, and move forward with screening. So our strategy is really a two-pronged approach to increase those up-to-date screening rates. The first of which is a public awareness campaign to really feed the screening funnel. And the idea there is to promote the importance of screening as cancer prevention, to allay both those baseline fears that we know are there among the population around colorectal cancer screening that were there before COVID. But we also have to layer in that additional fear and anxiety of going into a facility or having interactions outside the home or your socially distanced or small circle during COVID-19. And really, we wanted to drive to that patient navigation. The second piece of this is that centralized patient navigation to drive screening completions. And with that, what we wanted to do was to stratify patient colorectal cancer risk into low, medium, and high, and based on symptomatic or asymptomatic, so that we can provide screening options and educational materials that fit your risk level. We also wanted to increase screening compliance through patient navigation and connect patients with providers, both primary care and our GI docs, and then closing any delays in timely follow-up. So specifically, if someone goes into a stool-based test, if they do have an abnormal result, how are we closing the gap between that positive test result and that follow-up colonoscopy? Because we know that screening is not complete until that colonoscopy is done. So with the campaign, who we're trying to reach is twofold. It's heavily weighted to individuals and patients. So about 80% of our campaign is focused on that, and then 20% on providers. From a patient perspective, we are targeting those who are 45 to 65 and really prioritizing the 45 to 54 for our media buy. The reason why we're focusing in these age ranges is specifically because of the increase that we see when people hit the age of Medicare, but also we know that people are slow to get started. And if we can instill that behavior early, then we'd like to kind of rinse and repeat and keep them going through that process of screening. We do focus on some community segmentation by race and ethnicity. So we are reaching out to those in the Black community and the Hispanic and Latino community as well. And you'll see when I get to the markets that we're starting this with, where we're trying to focus in some areas where there are higher populations of the Black and Hispanic population. From a segmentation perspective, we are trying to reach those who are unscreened or late on screening. So if they're 51 in a day, they're way past overdue. Those are the folks that fall into that average risk category. But we also want to be reaching out to those who are in a high risk category from a standpoint of family risk, a hereditary or genetic link, or comorbidity that may be more highly associated with colorectal cancer risk, as well as those who are experiencing symptoms. We know we need to get them into a clinical consult as soon as possible. And then again, those Black and brown communities. Our key messages for the campaign, the main message is really cancer did not stop when COVID-19 started. So we're trying to communicate that colorectal cancer screening can save your life, that all screening options are safe, and that there's several ways to get screened for colorectal cancer, even at home. And so the takeaways there are really that it's important, it's safe, and I have options. And if people remember that it's important, it's safe, and I have options, then we're more readily available to meet them where they're at. And so with the campaign, there are several calls to action depending on which audience you fall into. So our consumers or patients that we're trying to reach, it's really to find the screening options that are right for you and get screened now. For providers and payers, it's for them to use the patient navigation tool to help them engage their patients, to get that conversation going, to really overcome that inertia. And then for our allies like you, it's to share your story, to emphasize that importance of screening and to promote the utilization of the navigation tool. For our campaign, we did some research, both leveraging the research and insights that were out there pre-COVID, but also looking at some of the behavioral data that has happened and that we've seen in the research as COVID has progressed. And really what we leaned into was that everyone is feeling very out of control right now in many capacities, and this is actually something you can control. So we're leaning into the insight of you are in control right now. This is not a message that you will necessarily see verbatim in the creative or in the campaign, but that's really what we're pivoting on, to try to have people get that sense of ownership that this is something I can control, so I should. So the awareness campaign creative will be launching actually the day that you view this on Monday, November 9th, and I'll show you the markets that launches in. We are focusing heavily in digital media, specifically from the standpoint of being able to reach those target audiences that I mentioned before. So the concept that we are working into this is that the world has changed, but your risk for colon cancer has not. And all of the creative will have these images where it's really kind of that the world has been flipped on its head. So you'll see several images in play with, again, this headline of the world has changed, your risk for colon cancer has not. with a call to action that really warms up the audience about the idea of taking control of your health and getting checked now. On the right side, you actually see what this looks like for the provider audience. And so here, again, the world has changed. The risk for colon cancer has not, with the message that patients report being concerned about the safety of getting screened for colon cancer right now. The good news, they also report trusting their healthcare provider's guidance on screening options, and the call to action that your patients are waiting to hear from you now. So you'll see us really leaning into that message of now to communicate that urgency. As I mentioned, we are launching today, November 9th, as you view this. We did complete a 2-week test in 3 markets in early October. Those markets were Philadelphia, Washington, D.C., and Houston, Texas. The launch that we are actually doing today will extend beyond those 3 markets into Atlanta and Phoenix, and then through Q1 of next year. These are some of the additional markets that we're looking at. As I mentioned with our target audience, what we were looking to do was to make sure that we were reaching those audiences, specifically that have some additional disparities. We see that the Hispanic population have lower screening rates overall, and we know that the African American community does experience higher incidence and mortality than non-Hispanic whites. So you'll see that the markets that we're focusing on have higher population densities overall, but also index very high within those subcategories as well. In terms of where you might see, if you fall in one of those markets and in our target audience categories where you might see this, again, we're leaning heavily on digital. For our patient audience, it's going to be a mix of Facebook and Instagram. And then for our primary care provider audience, we're leaning heavily on LinkedIn. More and more providers are using LinkedIn for thought leadership. And so we are following where people are. In addition, you see here the Washington Post. This is indicative of what is called a programmatic display buy. So this is where those ads that follow you around the internet, this is where we can do some behavioral and contextual targeting to actually reach our audience directly. And in our creative test, this actually performed very well in our African American and Hispanic audiences in terms of reaching them specifically with that awareness message. So in terms of how this then works, because it is a 2-prong approach, the awareness creative drives a user, an individual, to click an ad or to enter a direct link to actually go to our navigation. From there, they will end up on a navigation tool landing page. The entire purpose of that page is to get the user to click and to set the user's expectations on what they'll be asked to do, what happens when they complete it, and about how long it'll take. Once the user clicks start, they'll be taken to our form and they'll complete the questionnaire. The number of questions will really vary based on the responses. So there are 4 sections. One is a contact form. One is some personal information about your personal health history. One is family health history. And then we have a demographics page. The idea here is not to ask so much information that we are holding lots of personally identifiable health information, but really to get enough just to stratify that risk. And then once the user completes the questionnaire, they'll be recommended a screening or a medical consult. So within the navigation itself, they'll be served a recommendation based on the risk factors and then provided a link to education materials. For the phase 1 launch that is happening today, that will be the end of the user experience. But what we are actually building out for Q1 of next year pulls in additional functionality so that we'll actually be able to help identify providers by zip code, either primary care or GI doctors. We'll actually do some follow-up and create an escalation path to our patient and family support navigators to ensure that people are taken all the way through the point of screening, that screening test is completed. We can capture the actual result and then based on the result, navigate them to the most appropriate path, either a congratulations, you're all clear, you're set to go for the next year, 3 years, or 10 years, depending on your provider's recommendation, or do we need to get them to that follow-up screening, or if they are diagnosed with cancer, to get them into our care pillar with Andrea's team. So with that, that is an overview of our Screening During COVID campaign. Again, it launches today. I would welcome you all visiting the navigation landing page. That address is quiz.getscreened.org. Again, quiz.getscreened.org, and take a look through it. And we welcome feedback. We are optimizing as we go, and we're excited to launch this to actually support patients through screening and match people to the resources that they need to ensure that screening is completed. Thank you.
Thanks so much, Trudy. I know we're all committed to removing barriers and making everyone aware and comfortable with cancer screening. So everybody, please share your story and share the website, quiz.getscreened.org. I know we don't have too much time left, but I want to ask a few questions of our panelists while we have everyone. And I know there are some things that are weighing heavily on people's minds. And while we were talking about screening, Trudy, I'll start with you because 2 weeks ago, the U.S. Preventative Services Task Force released a new draft recommendation to reduce the starting age for colorectal cancer screening to 45, which I know we were all holding our breaths for and very excited to see. So tell us a little bit about what this means for our community and access to life-saving colorectal cancer screening.
Thanks, Andrea. And this is such exciting news, and it just really is hard to overstate how much of a huge step forward this change in the guidelines will be once approved. It will save lives. The Preventive Services Task Force shared with us that the evidence has just become increasingly apparent that screening at this earlier age is important. If you look at the numbers, around half of all early onset colorectal cancers incidence is among those who are 45 to 49. So reducing the age of screening will have immediate impact. Because the screening is preventive, this has implications on your insurance coverage under the Affordable Care Act. So this will help many people to get screened and many cancers to be caught earlier or prevented entirely. Now, not everyone has insurance, and we know that. So the Alliance will continue its work to increase access to life-saving screening for those who are uninsured or underinsured. And I think that we need to remember that as well. But again, it is a real testament to the incredible advocacy of our allies and our colorectal cancer community of the work that we've done to raise awareness of screening and what screening does to save lives. So thank you for your efforts to this community. You all should be very proud, and we're very excited. The comment period opened on October 27th, so we're about halfway through that. If you would like to show your support, there is a link in a press release on the Alliance's website where you can actually sign on to a letter of support and share your story. Thank you, Andrea.
Yeah, thanks so much, Trudy. I echo the appreciation for our community and all of the support, and we'll put the link in the chat here so people have that accessible. And once again, just a plug for calling our helpline at the Colorectal Cancer Alliance to talk with a certified patient and family support navigator if you have any questions about your own screening or for a screening for someone you love. And I'm going to move on now to Carol, Katrina, and Dr. Liu in that order, if you don't mind. Just any final thoughts you can share in terms of recommendations to patients who are watching for how to take care of themselves right now during the pandemic with all of the fear and anxiety we know people are experiencing. Carol, we'll start with you.
I really strongly recommended that they involve themselves in activities that are calming and bring them reassurance, whether that's spiritual, whether that's the drive-in church services. I think that people need to reach out. There are still online support groups, and really try to listen to your healthcare provider and not so much the news, and try to regain some control over how you're feeling with your healthcare.
Yeah, great point. Shout out to the Alliance support communities as well. I'll put in one more plug for Blue Hope Nation and Ally to Ally. And we've seen so many of our community members connecting even right here in the HUVA conference app So making sure that you are staying connected, I think, is a really important piece of the puzzle. Katrina?
I think that in terms of treatment, clinical trial versus standard of care, just choose what feels comfortable for you and your family, and know that we've implemented the safety measures to decrease any risks that could occur with COVID-19 infection. We don't want you to not do treatment because of that, and just ask the questions, ask your providers, ask your nurses, go to the support hub. I think it's really important to just to reach out and talk it through and make sure you're comfortable with the decisions that you're making.
Yeah, great point. Dr. Liu, what would you add in terms of managing anxiety and fear and treatment planning moving forward?
Yeah, I think you've heard a lot of strategies, even in the last 45 minutes, in terms of dealing with everything that's going on. And I got to tell you, I mean, our patients, I always joke, are literally the smartest ones in the pandemic, and really have just shown that you can receive treatment and be safe. You can live your life and be safe, but you have to be smart about it. And I think our patients are really smart. Our patients and their caregivers also deal with a lot of uncertainty. And that's why I think, to a certain extent, our patients are really the best equipped to live their lives, even though there's all this kind of chaos going on. But to echo a lot of the things that have been already said, I mean, you got to go out there, you got to have fun. You've got to try and stay off media from time to time and just take a break from it. You got to get out and get some exercise. You have to spend some time in mindful meditation. These are all strategies that a lot of our patients are using, but it's just a good reminder to kind of get out, get exercise, take great care of yourself, and to make sure that you just know that the hospitals and your caregivers, both inside and outside of the hospital, are there to help you, are there to keep you safe. And I think that we've really proven that over the last 6 months.
Yeah, fun. That's a really important takeaway. Thanks for reminding us. Well, thank you so much again, Dr. Liu, Katrina, Carol, and Trudy. This has been so helpful, and we can tell by the chat that people are really excited about this topic and have been really happy to be listening to you today. So thanks again for being here.
Thank you.
Thank you.